simulation modeling, and previously he's worked sort of in the broader field of development economics and with other colleagues such as Richard Smith. So I'm going to stop there. They'll speak for about 20 minutes. Then we have presentations from two other speakers. And at the end, we'll have time for questions and answers. What I would ask you all is, can you write your questions in the chat box? And then we'll try and sort of highlight that, sort of pick those questions which most people ask. And also just to say that C19economics.org also runs a discussion forum. So if we don't have time at the end of this meeting for questions, you are welcome to enter them into that discussion forum, and we'll try and answer and start a discussion in those areas too, because our site is not just a website, but we're trying to create interaction and networking between health economists working in this area. So I'll stop now, and Marcus, over to you.
Thank you, Anna. I'll just make sure that my screen is sharing properly. And I'll just turn off my video because I'm looking at the screen the other way, so it'll look a bit strange. Right. So this presentation, the macroeconomic and health impact of COVID, the meeting of two communities, it's part of a project which is funded by the Wellcome Trust, managing COVID-19 epidemics in low to middle income and crisis affected settings, epidemiological and economic evaluation. And the summary of this work is the macroeconomic working package. It's something that Henning, Jensen and I have been working on, particularly Henning's the senior CGE modeler at LSHTM. But there have been a lot of other people who fed into this because of the epidemiological modeling as well, and all of the costing. We have discussed this work with representatives of the Ministry of National Health Services in Pakistan, and the scenario designs that we're presenting, they don't exactly reflect reality, but they are based on the types of lockdowns that were applied in Pakistan between March and June, but they're modeled as forced rather than smart lockdowns. But we also have an intermittent scenario with the longer term interventions, which I will explain. So why do we put macroeconomic and epidemiological modeling together? Well, the benefit of macroeconomic models is, of course, that the health impacts of COVID occur across the population and therefore affect all sectors of the economy. And therefore, with our macroeconomic models, which capture all of those different sectors, we're able to capture the productivity effects across the economy. Also, of course, the non-pharmaceutical interventions themselves have impacts across the economy and apply to different sectors. So that there's the macroeconomic approach is important. At the same time, the epidemiological models can be used to, of course, simulate how the pandemic will progress. But as well as that, they're used to determine how those non-pharmaceutical interventions will reduce transmission and so on, so that we can adjust the productivity impacts when we model the impact of those non-pharmaceutical interventions in a macroeconomic model. Also, it's quite important that these two models work together, because it allows us to have consistent specifications of the timing, the extent, the duration of those non-pharmaceutical interventions, so that we can ensure that the results are consistent between those two models. But also, what we like to do with our macroeconomic models is to present health impacts alongside macroeconomic impacts to give a holistic output, so that policymakers can compare both the health and the macroeconomic impacts together when decision making. The modeling method we use is computable general equilibrium modeling, and that's a system of equations which specifies the behavior of different agents in the economy. So we have the firms who take the labor, capital and land together with intermediate goods, and they combine those to produce goods and maximize their profits. And we specify that in our equations. The households, they're the main consumers, they supply labor to the economy, and we specify their behavior, the behavior of government that collects taxes, redistributes as benefits, foreign agents as well. So we have this system of equations that specifies how agents behave in the economy, and then we calibrate those equations with real economic data. That is taken from the GTAP database in this case, which contains all economic flows by sector in the Pakistan economy. Also, we disaggregate the households to 4 representative households based on 4 province populations using the household survey for Pakistan. And that enables us to separate out the KPK, Punjab, Sindh and Balochistan households in our Pakistan modelling. The modelling method itself, we run these simulations for 2 years. It's a dynamic model and we've opted to run for 2020 and 2021. We can do it for longer periods. The initial simulation is the thing that we run first. So we solve the model to find a do nothing, or a counterfactual, we call it, equilibrium. So what happens if we don't do anything in the Pakistan economy to change the Pakistan economy over the coming 2 years? We then model scenarios which reflect the health burden and policy scenarios together. So we shock our model in some way. That might be a labour force shock to reflect a change in health, productivity to the workforce. It might be a business closure and so on. So we shock the model to represent that new policy simulation, and we find a new solution based on those constraints, and we calculate the difference between that and our initial simulation to estimate the macroeconomic impact of that policy simulation. The policy simulations that we run have two main types. The first is just direct health effects. So we only model the illness only impact for an uncontrolled pandemic. We use a conservative basic reproduction rate of 1.7. And the epidemiological models that we use, we have separate epidemiological modeling of those province level epidemics across those different household areas. The other type of modeling that scenarios that we have are the non-pharmaceutical interventions together with those same health effects with their mitigations. And they're applied in two ways. We apply them either for a 10-week period from March to May 2020, from the time that the lockdowns did take place in Pakistan up to May 2020. But also we apply them intermittently with 1 month lockdown, 2 months opening up from March to December 2021. So that's over a much longer period. So those are the types. The actual lockdown measures that we capture include business closures, where we reduce capital and labour supply to the economy to reflect the closure of 20% or 40% of non-essential businesses. And we can do that because we've got a sectoral model. For school closures, we estimate based on the fertility rate, the number of households who have working, we actually estimate by working mothers with dependent children, and we assume that if they are employed, 24% of female labour participation in Pakistan is used for that, then they will take time off work because of school closures. Home quarantine increases work absence from 10 to 14 days or 7 to 10 working days per infection. So those are the lockdown measures. So these are the scenarios that we actually model. The first is an uncontrolled COVID-19 epidemic in Pakistan. Our scenario 2 applies lockdown measures just from March to May 2020, and they include complete school closure, 20% closure of non-essential businesses, and home quarantine. Scenario 3 is the same as scenario 2, except we increase the non-essential business closures to 40%. And our scenario 4, we apply the lockdown measures for 1 month on, 2 months off from March 2020 to the end of the simulation period. But the actual lockdown measures themselves are the same as scenario 3 with the 40% non-essential business closures, school closures and home quarantine. In order to parameterize those scenarios, we use an R0 of 1.7, and the epidemiological models generate age-specific cases, hospitalizations, ICU admissions and deaths by 5-year age groups. When we impose the health costs upon the model, we use hospital bed day costs and we apply them to all ages, because regardless of your age, that will have a cost to the economy. With regard to the labour supply impacts, we estimate those for 15 to 64-year-olds and then adjust that by labour participation. So we only take labour away from the economy from those who would actually be engaged in employment in the economy. The durations of illness, we assume that anyone who's hospitalised will not return to work for 7 days after they've been in hospital. For disease only, we assume that someone will miss 7 working days, or under a home quarantine scenario, that will increase to 10 working days. Hospitalised individuals will miss 11 work days, and their costs will include 8 patient days in hospital. For ICU, 13 working days, with 10 hospital days, 2/3 of which spent in ICU. And for fatal worker replacement, we assume that when a worker dies, on average, there'll be 105 work days from the first year and 250 from the second year, because they'll obviously, that labour supply is permanently removed. And these are the costs per day. Now, with our model, we use a satellite epidemiological model. And what that means is that we run the epidemiological simulations first, and then we impose them on the macroeconomic model. But it's helpful to give an illustration of the pattern of the sort of effects that our model, that epidemiological model produces, in order to understand the macroeconomic impacts. So hospital admissions, cumulatively around 2.2 million over the 2 years for our uncontrolled pandemic. But what you can see is that all of the interventions that we model postpone many of the health impacts into the second year. For scenarios 2 and 3, with the school closures, business closures, and home quarantine, the actual number of admissions by the end of year 2 are fairly similar to an uncontrolled pandemic, but they are lower in scenario 4 with the intermittent lockdown. Another pattern, another thing to mention is that the deaths, they similarly, in the uncontrolled pandemic, they occur in the first year and are pushed into the second year when we apply interventions. But those deaths, of course, will accumulate. So someone who is removed from the labour force because they've died in 2020, that impact will accumulate in future years. So that's important as well in explaining our effects. At the household level, what we see is that in an uncontrolled pandemic, the more densely populated larger areas, Punjab and Sindh, see a disproportionately large number of cases. But when we apply the interventions in the year for scenarios 1, 2, and 3, in the first year, because the pandemic is subdued, we get a more even household distribution of cases. But then once the pandemic is uncontrolled, then we get a more focused impact again on the densely populated areas. But that same pattern is seen to some extent in the intermittent scenario as well. So those are some of the inputs. The other inputs that are important that come from the epidemiological model are the labour force losses. So what we do here is we take our clinical health outcomes from the epidemiological model, and we apply age-specific labour participation rates to estimate how many of those will occur in the workforce. And so what we can see here, again, similarly, the uncontrolled pandemic, see the bulk of the impacts in the first year, and in the other scenarios, they're pushed into the second year. Again, by the end of the first year, scenario 2 and 3, the impacts are fairly similar. But if we look at the labour losses as highlighted here, you can see that the accumulation impact means that there's a lot more that feed into the second year from the uncontrolled pandemic, because they've been accumulating over time. And we get a similar pattern, but lower levels for the other scenarios in terms of the fatalities that feed into the labour force. We can see here that hospitalised patient labour losses around sort of 8.5 million work days, but they're 10 times larger. Contribution comes from those who are non-hospitalised, who don't go into hospital, because there are so many more people in that situation. And again, we get the household impacts, which I've described earlier. So these are the macroeconomic impacts that come from those simulations. And just to explain how we derive this table, the top line is the full impact of the scenarios. So in the case of scenario 2 here, the top line is the impact of the business closures, the school closures, the home quarantine, everything, the health impacts all applied together. But with our simulation models, we don't like them to be a black box. What we do is we run the separate elements individually. So we can run just the business lockdowns, just the school closures, and so on. And thereby we can decompose how much each of those elements contributes to that macroeconomic cost. There's a little bit of non-linearity there when we run them in isolation, but it gives an impact of the contribution that each element makes. So what we can see is that the unmitigated, uncontrolled pandemic impacts are around $720 million, which is around 0.12% of GDP cumulatively over the 2 years. These, as you can see, are particularly driven by labour supply losses, and those labour supply losses are primarily in the first year, the non-hospitalised people taking time away from work. But by the second year, around 85% of those macroeconomic impacts are coming from the cumulated fatality impacts from those who have died. For scenarios 2 and 3, the impacts are much, much larger, as you can see. And those large macroeconomic impacts are primarily driven by the business lockdowns. So there we can see 5.5 billion in the first year from the 20% business closures. The next most significant impact in those scenarios is the school closures, but obviously not substantial as the business lockdowns. So we can see there, and the labour supply impacts economically by the end of the second year are fairly similar to the uncontrolled pandemic. Also, we can see that the 40% business closures approximately double the impacts as well. So we can see that this has very substantial macroeconomic impacts. However, what we like to do with our models is, as I said, we output the health impacts alongside the macroeconomic impacts. And that's what we can see at the bottom here. Because by doing that, we can see how those interventions in scenarios 2 and 3 are deferring the deaths and the critical cases into the second year. And therefore, what you could say is that this intervention is potentially, for hundreds of thousands of people, it's improving, it's giving them a year's extra life, or deferring the time at which their complications arose. And in that sense, it's potentially saving hundreds of thousands of quality adjusted life years. We could estimate, for example, that the cost per saved life per year would be less than $20,000 US, which could perhaps be viewed as cost effective by Pakistani cost effectiveness thresholds. But by outputting these health impacts alongside the macroeconomic impacts, we can see the benefits. The scenario 4 with the intermittent lockdown, those losses are very substantial. In the first year, they are 20 times the size of the uncontrolled pandemic, and by the end of the second year, they're 50 times the size of the uncontrolled pandemic. The macroeconomic impacts from the health impacts are slightly smaller because the health impacts are reduced in that scenario, but it's unlikely that this would be seen to be cost effective. In fact, the health effects, the number of critical patients is reduced by 42%, so is the number of case fatalities, and the number of severe cases is reduced by 43% by the end of the second year in that scenario 4. So it is having a health impact, but it's not, it's very, very costly. Also with our model, we're able to decompose the different elements of GDP and see what the contributions are. What we can see here is that those business lockdowns and those GDP losses are driven very much by substantial real private consumption losses. What's happening here is that households are having reduced income because they're getting reduced returns to land, labour and capital factors. And also because private consumption makes up for 70% of final demand in the Pakistani economy, that's going to have a substantial impact, as we see, on GDP. Investment impacts are actually disproportionately large from this, and that's because the reduction in capital and labour supply is driving up the cost of investment. Investment demand falls, and therefore, particularly while those business closures are in place, we get an accumulation of investment impacts, particularly as you can see in scenario 4. So that's a costly element of the business lockdowns. The real government consumption impacts are actually positive, and that's because with these particular business lockdown impacts, salary levels actually drop. And in our macroeconomic model, the way that we have closed it is we've assumed that the government budget will be maintained. The government draws revenue, for example, from taxes, but the government revenue will be maintained, and therefore they will have a higher output from those reduced salaries.
Mark, there's 2 minutes.
Right, okay, thank you. School closure and quarantine are negative across the board because they're driven by labour supply impacts which evenly affect all of the sectors of the economy. So I'll just rush through that a little bit. We can see again when we can decompose our macroeconomic impacts by households as well. We've got the household distribution, which I've previously mentioned, but you'll notice here that the hospital costs have a positive macroeconomic impact. That means that the expansion in spending on hospital costs is actually having a positive impact, even though of course it's reflecting having to treat more people. But these don't counter, for example, the negative impacts from the labour supply losses. But we're able to decompose those. So some of the conclusions from this are uncontrolled COVID-19 baseline scenario impacts suggest that according to our simulations, we would expect symptomatic cases of 35.9 million, case fatalities of 345,000, and GDP cost at the end of the second year of 721 million, sorry, in 2020, 721 million US dollars, which is 0.12% of GDP. In fact, the actual outcomes by December the 31st were 485,000 confirmed cases, 10,000 case fatalities. So if our simulations are correct, that might suggest that Pakistan's smart lockdown strategy did reduce case fatalities. The GDP cost is not yet known in reality. In terms of the lockdown scenarios that we've modelled, the one-off 10-week lockdowns impose a postponement, but not an aggregate reduction of in clinical outcomes, and those GDP costs are 10 to 20 times an uncontrolled baseline. The intermittent lockdown does postpone and reduce the aggregate impacts by the end of the second year, but they're 50 times the cost of the uncontrolled baseline. The negative impacts of business closures, in particular, those particular lockdowns, cause investment impacts to persist and to accumulate. But there are substantial QALY gains in 2020, and if we limited the duration of these lockdowns, they could potentially be viewed as cost effective, and they could also be used to buy time for vaccine delivery. So in a sense, some of these scenarios could be potentially worthwhile. Epidemic non-pharmaceutical intervention costs will also most affect the most popular provinces when the pandemic rages. With regard to the methodology, we hope this shows that the linking of these epidemiological and macroeconomic models is important for the health and economic assessment of pandemics, and that by in parallel being able to output these health and macroeconomic indicators together, it enables us to compare, it enables a more holistic policy assessment, and hopefully presents valuable evidence that can be used for policy making. I'll stop there.
So thank you, Marcus, and also Henning, for that fabulous work. We'll come back to questions at the end, but I'd like to move on now, apologies for background noise, to Dr. Mark Blecher. Mark is the Chief Director of Health and Social Development in the National Treasury of South Africa, so we're very pleased to have him here today and to spare time for us. He actually is a sort of trained health economist by profession with a PhD in health economics, and his work currently encompasses many areas, including national health insurance research, but also work on health and social protection, leading key committees of that in South Africa. He's published widely, and he's also been chair and has a lifetime of experience dealing with our, well, still current pandemic of HIV. He was co-chair of the UNAIDS Economic Reference Group and works regularly with other global organizations. So welcome, Mark, and over to you.
Thank you, Anna. Good morning, everybody, and Happy New Year to everybody. And my thoughts go out to everybody whose families are going through a rough time through COVID at the moment. I know many people are actually affected. Nuru, I think you're going to change the slides for me. If you can go ahead. I'm talking about aligning the EPI and economic modeling in South Africa, and really want to focus a bit about how I think South Africa learned some lessons from hard experience. I'll talk a little bit about what our models do and some questions that maybe are useful to policymakers and about bringing decision makers together. Thank you. Next slide, Nuru. So in South Africa, although both health modeling and macro modeling was done, they were not very well integrated initially. And the economic perspective particularly was not heard very well in the early period. And there was a lot of panic around the early days of COVID, and it led to a very early, very severe national lockdown at stage 5, which involved basically stay-at-home orders and lasted for many months. You couldn't even exercise outside your home. And the president wanted a very substantial economic package of around 10% of GDP to a wide range of interventions, about 20 billion of that to health. But this very extensive lockdown led to most key parts of the economy being closed for a lengthy period. And there was a huge emphasis on trying to enforce this with the police out, the military out. Around 286,000 people were arrested. Many supply chains got disrupted. Even getting PPEs into the country became more difficult because the economy and the supply chains were so disrupted. And the whole initial few months focused more on closures rather than how to reopen safely, or how to make workplaces safe, or how to transport things safely. Next slide, please. So we early on had quite a lot of good epi modelers, and our National Department of Health had the good sense to bring them together in a national modeling consortium. And this is one of their fairly typical early SIR models, which showed these fairly typical curves. This one is showing curves for cases and ICU beds and admissions and deaths and so on. And then also we had a national costing consortium in the health sector. So this was able to develop, based on the EPI model, a whole costing model, which led to a national budgetary response and informed this 20 billion budget allocation. So this was all very useful, but the national model didn't really have sectoral sub-analysis, like I think the UK and some other models do. It didn't really look at schools or particular sectors in the economy and so on. Okay, the next slide. So then, here this level 5 heavy lockdown was, in place for a couple of months, and problems started to emerge. Huge queues for food, like 5-kilometer queues for food, massive unemployment, which started at between 26 and 40%, depending on whether it's the formal or wider definitions of employment. This is pre-COVID. And then you started with big academic studies like the early NIDS-CRAM survey suggesting that this lockdown had led to the loss of 3 million jobs. And then Statistics South Africa coming in, showing that formally our official statistics agency by Q2, 2.2 million jobs lost in a country that already has severe unemployment and equity. Government putting 60 billion into social grant supports, including new grants for the unemployed, into similar amounts into unemployment insurance. But at the same time, because of this lockdown, many of these offices being closed, huge queues at post offices, which pay some of our social grants, and the costs of supporting millions of people continuing to rise week by week. At the same time, tax revenue dropping massively, both due to the economic decline and measures to protect business closing. So this prolonged lockdown became progressively more difficult to sustain from various approaches. And I think this depends quite a lot on the specific fiscal space and debt profile of specific countries. And South Africa's fiscal position and debt profile was a much kind of more borderline or worrying than a country like the UK, for example. And then you start seeing the collapse of whole sectors, important sectors like early child development, which after 3 or 4 or 5 months of lockdown and not getting fees from, many of our early child development centers are paid through run through NGOs, paid through fees. And you start seeing huge numbers of poor woman ECD teachers losing jobs, arts and culture industry being decimated, informal workers, a lot of these 2 million job losses. And all of this despite large relief programs. And on the health sector side, massive drop in chronic disease visits, HIV visits, etc. Next slide, please, Nuru. And then this economic and fiscal storm and looming debt crisis starts getting even worse. By the time of the medium-term budget policy statement, GDP projections to decline by 8%, the deficit to rise to 15%, tax revenue to decline by more than 300 billion rand. And this is not just for 1 year. These effects to go forward for 3 to 4 years. Interest payments, debt starts rising. Interest payments start exceeding the entire national health budget, the social development budget. Debt starts rising from 50% to 95% of GDP. And then panic starts setting in on the fiscal side, and people start trying to stabilize the fiscus in a climate that doesn't have low interest rates, doesn't have big fiscal reserves. And so one sees the fiscal framework starting to be cut in the years going forward, 300 billion coming out of expenditure, the health budget going forward into next year being cut by as much as 40 billion by the outer year, the health department going into a serious second wave, driven by a mutant strain, not that different from the UK, being dealt with by the health department with significant budget reductions because the economy has collapsed and there aren't the fiscal reserves to support it. Next slide. The slide on the left is what our Minister of Finance calls the closing the mouth of the hippopotamus. So revenue, the lower line, dropping substantially, expenditure, the upper line, rising significantly. And the graph on the right being national debt, which in the scenario that does not cut expenditure going forward, debt rising from 50% of GDP to 130% of GDP. And then the decision makers saying, okay, well, we're going to cut expenditure going forward in the budget because of this collapsing fiscal situation to try and contain debt at 90% of GDP. Next slide, please, Nuru. And you see revenue plummeting. Next slide, please. You see gross fixed capital formation plunging. Next slide, please. You see the labor market, job losses being a serious problem. Next slide, please. And these are just a few key fiscal indicators. I won't go through all of them, but you see, look in the 2021 year, that's the second column. Government tax revenue 1099 billion and spending 1.8 billion, 800 billion difference between government spending and revenue. So serious situation. And then the next slide, slide 12, please, Nuru. And here you see government starting to cut expenditure going forward because not enough attention is being given to the fiscal and economic implications. And you see government in a way panicking. And in the next financial year, the spending ceiling declining from 1.5 trillion to 1.4 trillion, an 80 billion reduction in the budget, including the budget because the economy is collapsing. Okay, next slide, please. So on the macroeconomic modeling, the lockdowns have the most direct effect. So even my colleagues in the WHO talk about, the effects of the COVID, the epidemic itself, but then the further effects from maybe not a well-executed lockdown. And, the models shock the economy on the demand and supply side, and our macroeconomists particularly focus on what that means for growth. They run a multiplier analysis similar to a CGE model. It sounded a bit like the Pakistani model in a way, although not as complicated. Our Reserve Bank runs several production side models looking at different sectors. And you see these projections of 7.8 to 8% GDP decline. But initially, as I say, these results not shocking decision makers to be a bit more cautious. Next slide, please, number 14. So this is just an early economic model which colleagues interested in the South African experience can look at by Channing, Arndt, and colleagues. Next slide, please. So it looks at channels at which the lockdown affects the economy, models several scenarios. And next slide, slide 16. It looks at different sectors of the economy, which have a mild decline, a moderate decline, a large decline, and a serious decline, etc. Next slide, please, Nuru, slide 17. And you start getting publications about the unintended health consequences of the pandemic, with huge swathes of the health service not functioning properly, people not picking up chronic medicines, etc. And next slide, please. Increasing focus on this labor market and poverty impacts of the epidemic and the response to the epidemic. Next slide, please. And a number of global models, a bit like the Pakistani model that was shown, but this paper many people will know, which tried to look at starting to focus not just at the whole economy lockdown, but can't there be more focused approaches to this? I won't go into the details of this and other papers. And then next slide, slide 20. you see WHO in their December publication starting to come out more formally, saying, colleagues, we need to think about the effects of these lockdowns on the economy. We need to balance the effects on the health system and the economy, and proposing a 5-step decision-making framework, which includes Section 4, establish dialogue and decision-making processes where you deliberate on both the effects of the health and the economic effects, and try to affect the, make a decision based on both considerations. Next slide, please. And then South Africa heads into a second wave, and its second wave is bigger than the first wave, and it's driven by a mutant strain. And the country can't afford to go into the level 5 lockdown that it did initially, because its fiscal reserves are gone. And so it now sets the response at level 3, not level 5. Businesses remain largely open, with more attention to safe working environments rather than closing them. Almost all the supply chains are working. Mask wearing becomes mandatory by law. The interventions become much more geographically targeted. Contact tracing apps, occupational interventions, social distancing, restrictions on meetings, curfews, alcohol restrictions, focusing on the vaccine, and not having the reserves for the income support that was there in the first phase. And early data suggests that tax revenue is starting to come back, the economy is starting to swing back, and so on. Next slide, please. And so some questions of interest to policymakers are, in making these decisions, what are the technical ways to consider both health and livelihood implications when considering competing policy options? How to feed through lockdown and other health-driven decisions onto outcomes like poverty, health, HIV visits, missed job losses? What are the ways of keeping the economy running while protecting workers? Technical methods like the Pakistani case of how you link epi and macro models. How long is the second and third wave going to go on for? What will be the effects of new mutations and vaccines? And how does that feed through into the demand and supply sides in the macro models? And then sectoral specific analysis, like can one keep schools open or not, or whatever. And then the last slide, I think that just conclusion, then it seems essential to consider the health and economic effects of interventions, especially if they're prolonged. These models are not straightforward, but it is important to bring them together methodologically, but also the important perspectives of both sides here are brought together to make better decisions. There's some good papers with combined models, but we need more technical work. We're heading into the largest global recession for decades. Part of this is COVID linked, but part of it is the response to COVID, and this will have long-lasting effects on poverty and inequity. Thank you, Anna.
Thank you, Mark. I think that was not a presentation we're going to forget the situation in South Africa. It must have been an incredibly difficult time for you all. I want to pick up, we have our last presentation, which is again focusing on the analysis and actually very nicely links to some sort of, if you like, as an example of the UK trying to deal with quite specific policies. I want to introduce Katharina Hauck. Just before I go ahead, can please, if you have any questions, do put them in the chat box and I'll try to come back at the end to those questions. Katharina Hauck is a reader in health economics and deputy director of the Abdul Latif Jameel Institute for Disease and Emergency Analytics, JIDEA, I hope I've said that right, Katharina, in the School of Public Health, Imperial College London. So for those of you who don't know Katharina, she's one of the few economists sitting in the large group of infectious disease modelers at Imperial College, which I'm sure many of you are familiar with. She's really specialized in the economics of infectious diseases and the economic evaluation of complex interventions. She's worked in many years in HIV and malaria elimination, and really focused on the health system response. And she holds a PhD in economics from the University of York. And she's currently advising the Cabinet Office as part of the International Joint Comparators Unit, which sort of sums up international evidence on the fight against COVID. So over to you, Katharina, and if it's a minute or two before the end, I'll give you a warning if it looks like it's going to be over time. Thank you.
Thank you, Anna. Well, and thank you for spearheading this initiative, which is, as we just heard, urgently needed. And thanks also to the previous presenters for the impressive modeling and also the sobering view on the South African situation that, of course, we all hope to help with our work. So I'm presenting here an integrated model as well. My colleagues, some of them are here at the seminar, are listed here, and we have really worked very hard over the past year to integrate a model that would allow policymakers to make these agonizing trade-offs that Mark just talked about before and that we see in our countries. So next slide, please. So the purpose of the modeling that we have done was to answer the question how we can keep schools open while constraining the epidemic and keep infections at a level so that the hospitals are not overwhelmed. We have integrated a dynamic model of SARS-CoV-2 transmission with a 63 sector economic model. And this model reflects sectoral heterogeneity in both transmission and economic interdependence between sectors. So we are modeling supply chains between sectors. Now, what distinguishes our model, I think, from Marcus's model is that we identify a control strategy which optimizes economic production, while we keep schools and universities operational and also keeping the infections within the capacity that we have for our hospitals. So it is an optimization model. The link between economics and epidemiology comes from contact patterns, survey data that tell us which sectors are more contact light and which sectors are more contact heavy, which sectors employ more or less workers, because if a sector is open, they will carry more infections back into the community. And if it is a sector where contacts are more intense, they will also carry more infections back into the community. And our modeling acknowledges that. We then give an optimal trajectory to policymakers on partial or full opening and closing of each of the 63 sectors, and calculate then the impact on the active workforce, community transmission, associated impact on disease transmission, and the impact on hospitals. So we optimize GDP in this application here over 6 months. And decisions are allowed every 2 months, and we respect the constraints that are imposed on the model so that we can make this constrained optimization work and optimize GDP. We make 3 alternative assumptions on the hospital capacity that we have, which now in retrospect sound optimistic, because we assume 12,000, 18,000 and 24,000 beds. Now, one of our co-authors, Neil Ferguson, said we shouldn't really consider 24,000 beds when that was in summer. But now, of course, we see that sadly we are nearly at 40,000 beds occupied now in the UK. Next slide, please. So here you can see the output of the model. So we have fitted the model to actual hospitalizations in England up to September. And you can see the blue line is the infections and the red lines is hospital occupancy. And we then projected infections for this particular scenario forward, and also hospital occupancy. You can see that the 3 horizontal gray lines are our hospital constraints. So this is the model that constrains hospitalizations at 18,000 beds, our medium scenario. And you can see the pattern that the dynamics of the pandemic, you can see is taken by the selective closure and opening of sectors as we move through. On the right side, you can see the economic configurations, and all sectors are lined up basically from the bottom to the top, all 63 sectors in our model. We indicate with colors how much a sector is closed. From blue, they are basically fully closed, and one, they are fully open. You can see the lockdown configuration in the shading here, and then going forward, you can basically get an impression how much each sector is closed down. Next slide, please. Our epidemiologist, David Hall, he calls that the lasagne plot. So here you can see basically the trajectory of hospital occupancy when we force the education sector to stay open at 80%, but optimize over the rest of the economy. And the associated GDP that we will accumulate over 6 months by following these different strategies. The gray line, the gray dashed line, is basically a fully open economy, so an unmitigated pandemic. The gray line that you see right at the bottom that is associated with 670 billion GDP is a strategy if we were to continue a fully locked down economy. And you can see then that really it doesn't take much to go from that scenario to the optimized scenarios, which are indicated by the colored lines. The rise in infections is actually not that high. But the increase in GDP is notable. Next slide, please. So here you can see the loss in gross value added across the 63 economic sectors for our three different hospital constraints. Now, obviously, the less constraints we have in the hospital sector, the more sectors we keep open and the less GDP we lose. So on the right side, that's economically the most optimistic picture. Now, of course, for health, that means we will have more, we allow more infections and we allow more deaths as well. So this brings home the trade-off. Now, on the left side, with the 12,000 beds, we can see that we need to close more sectors. We can also see which sectors we need to close and what is the associated GVA loss. Next slide, please. Now we had the problem of needing to model somehow the impact, the stringency of adherence to the NPIs. So how many people would adhere with social distancing or quarantining advice, how much they would wear face masks. And we implemented this with basically a multiplier on our effective reproductive number. And you can see that the assumptions we make on this is quite impactful for our findings. Now, this multiplier is informed by the multiplier that was, or by the adherence to NPIs that was observed during the lockdown, and you can read in our report how exactly we did that. But we can see that basically we are moving in a very narrow path between more stringent and less stringent adherence to NPIs, and this shows a further trade-off that we have between social liberties and the outcomes on GDP and on deaths or hospitalizations. Next slide, please. So this is my last slide. So we have a dynamic epidemiological model and a static economic model, which is the limitation of our approach. We, going forward, need to incorporate changes in demand, in labor supply, imports and exports. We have not done that yet. We also want to change the treatment of inventories. The problem being that if we don't model demand, we implicitly assume that companies may produce goods that are not immediately cleared on the market. Our main effort at the moment is directed to incorporating the impact of vaccinations. And we are working on extending it to LMICs to inform the vaccine modeling of WHO SAGE. We also want to refine the contact rates and do more refined modeling on the NPIs. With our modeling, we work very closely with the models that that the Imperial College response team is doing. So all our parameters are very much informed by these models. And we, although our model, of course, is simpler than some of the models that our colleagues are running, it's very much informed by those. Thank you very much.
Thank Thank you, Katrina. That's another example of a different sort of modelling approach where, we also use a dynamic model at the London School, but linking that to a static economic model, but really trying to optimise as well across that static model. So I think those provide at least the first and the third provide two different examples of different analytical ways of dealing with these trade-offs. I will ask you to put sort of chat in the chat box on questions, but there's one sort of topic which is emerging, which I know has been a topic also in the media and in other areas, about how we're defining an unmitigated epidemic in our modelling and what our comparator is. And one of the criticisms of the sort of comparator in the epi models has been that it hasn't adjusted. It's really been an epidemiological uncontrolled epidemic. And I noticed, Marcus, you were careful to use those words because people take individual sort of behaviors to mitigate themselves. So the argument may go as such that if we left a sort of unmitigated epidemic to proceed, we would still have a substantial economic impact. In fact, it may be greater later on as people start to withdraw and behave and protect their risk themselves, and may do it in quite an inequitable manner because those who are most vulnerable are not able to protect themselves. So I'd be interested in hearing maybe first from Marcus, because I know you have thought about this and also in your previous flu work. How did you decide your counterfactual? And if you wanted to have a counterfactual that was a non-policy counterfactual, but was still an individual response, how would you go about it, and what kind of data do we need to be able to do that? And maybe Marcus to you, and then maybe I'll come to Katrina and then Mark.
Yes, well, in ours, we haven't included any kind of behavioural response, simply because the data wasn't there to sort of reliably specify it. I mean, the way that our models work is that we can specify various counterfactuals. So in our particular case, we've gone for just the uncontrolled pandemic with no other difference. We could easily, if we could specify, for example, an uncontrolled pandemic with behavioural responses, then that could be easily used as a counterfactual instead. But I don't think we had the data in order to specify that. I ought to give Henning an opportunity to comment as well if he would like to, since he's worked on the modelling as well.
Sure. Just very briefly, I completely agree. Also with the question in the chat that that the baseline uncontrolled scenario should probably have included some kind of response in terms of private behavior. The uncertainty of the whole national epidemic and pandemic sort of playing out means that there's going to be massive uncertainty, even if there hadn't been NPI interventions imposed. So investment decisions would have presumably been revised, investments would have been postponed, maybe some of the inventories would have been and was brought forward. The whole consumption patterns, of course, being changed, even if NPIs didn't sort of restrict people from going out into the and consume in the hospitality sector, there would have been changes in consumption patterns, and that would have had economic consequences as well. So clearly, our focus, sort of narrow focus on the labor force impacts, health-related labor force impacts, and hospital costs. It does represent a very conservative estimate, and most likely costs are bigger and possibly quite a bit bigger than what we actually estimate.
Thank you, Henning. I wonder, Katrina, if you have any words to say on that too.
Yes, on how to incorporate behavior. I think that's kind of the holy grail of economic epidemiological modeling, to make behavior change endogenous to the model. Now, there are quite a few theoretical approaches to this, but very little empirical work. So I think that's a huge area for people who are interested in this to get into. In our model, our unmitigated pandemic is not quite unmitigated. So we have assumed a behavior change that dampens transmission. with a multiplier. However, we do not assume that this translates into the economy. So we do not assume that this translates into a reduction in demand or a change in the supply and the supply chains.
Thank you, Katrina. Okay, we've got 1 more minute to go, so I'm afraid I'm going to have to move to thank yous, but I just seen a couple of questions in the chat box. There's one particularly asking about the gradual easing of MPIs as vaccine programs are rolled out. So I will say there's one paper that went into the public domain yesterday from Warwick, and we'll put the reference up on our forum or put it in the chat, so people can see that. And I think there is more work sort of forthcoming from several groups on that specific question. And that sort of leads me into C19economics. We are trying to use it as a platform to post new research as it comes out, searching across economic websites and epidemiological ones. And we'd also ask if people do see interesting studies to tell us, so we can also post them up there so people from different communities get access to these different types of literature rather than having to search themselves. And again, any further questions, please feel free to put on our forum. So I'd really like to thank all the speakers today. All of you working in this field I know are incredibly busy, and I'm very pleased that you took the time to attend. I mean, particularly Mark, it must be a very difficult time for you now in South Africa. I'd really like to thank the sort of organizers, so Henning and Nuru, who as always have been wonderful and made this all run smoothly. And please do keep in contact with us. We're trying to make suggestions if you think there are other webinars or other topics that this platform can run. Because basically we're trying to sort of serve this broader audience. So thank you all very much. I hope to see some of you again in our future events. Thank you. Bye-bye.